Right, I think we're ready to kick off after hopefully a welcome cup of tea or coffee. This is going to be quite a whistle-stop session, but also we've got some really good contributors, excellent contributors, and they will no doubt raise the debate. So I'm hoping to get through it in half an hour with a few questions. So if you can bear with me if I'm sort of rushing things along a little bit. Our first speaker is Charles O'Hanlon. He's Associate Director of Delivery at NHS Newham, which is pretty much around here, isn't it? And he's been a management trainee and is working locally. He's also survived Hodgkin's lymphoma, which I think is an incredible way of getting insight into how the health service works. So I'm not going to prattle on, I'm just going to leave it to Charles.
Good afternoon, yes. So I'm speaking today about being a patient and not a commissioner, which is my other life. I've had an interesting cancer journey. I've unfortunately had cancer twice in my life, and I've seen it from a number of different perspectives. So I've been treated both in a district general hospital, and I've also been treated in a tertiary centre of excellence. And one of the things as a commissioner, which was really interesting while being a patient, was seeing how it can work so well, but also works so not well, and actually the contrast in between. So for me, it was really fascinating to see. I think what's interesting about the second episode was that actually what I had, both times I had chemotherapy, but I had a particular type of stem cell transplant, which was originally quite a revolutionary way to treat Hodgkin's lymphoma, but actually has become mandatory, has become the standard treatment, and actually is highly successful. I also received the second time, and this is the major contrast, significant counselling, information, family and carer support, complementary therapies and patient education, and that was really what made the difference to my experience. Today I'm going to talk about kind of my journey as a patient, and I'm going to try and take you through 4 things that I learned that were really important. The first is I talked about stem cell transplant being a revolutionary and being experimental. But actually, it's moved on so much that now it's being done as an ambulatory care, which is really different to traditionally how it was done. I'm going to talk about the value of the clinical nurse specialist. I'm going to talk about the third sector. I'm delighted today to be here with esteemed third sector colleagues, and I'm going to talk about how I feel the third sector their role in survivorship. And I'm going to talk about how we can use patients like myself to feedback on acute reconfiguration. First thing I'm going to talk about is ambulatory care. It was traditionally an inpatient stay where you could stay for up to 3 months in a room with a negative pressure room. And actually it's moved significantly onwards. Where I was treated, actually, they carried out this with a hotel partner. So when you go in for your chemo for the day, quite strenuous chemo, you'd go back to the hotel at night, so you'd go and you'd rest there. And actually it really makes sense because you don't need social care support, nursing support through the night. You actually just need a comfortable bed, somewhere to lay your head, and somewhere that's clean with nice food. And that's what it provides. And they're better than the NHS at doing that. So I guess in terms of the other reasons for it are that I felt that I actually was more empowered because I had to get up every day. I had to make sure I was washed. I had to go down to the hospital. It didn't feel like I was in hospital. And even the 6 days I was in hospital, it was amazing how I'm a young patient. I started to become dependent on the services around me. And it's amazing that actually having to force yourself to stay in a hotel was actually really, really beneficial for me. But for those commissioners, or the providers, the biggest saving is probably the crib saving. If you think about it, that 23 days it's come down to now from about 90 days. And actually in my case, I was only in for 6 days. So that's a hell of a lot of bed days saved when you consider it across the country. The other thing about this is that you don't have to use it for just cancer care. Actually, there's so many applications of using a hotel partner throughout the night where you don't need such intensive nursing support, and it could be used to trial how we could move from, let's say, we've made this move from inpatient to day case, and we could actually move much more to ambulatory care, particularly for medical interventions. I used to be a general manager in a hospital, and I actually have to be honest, I used to look at the clinical nurse specialist and go, that's a nice role to have, but it's not essential. How wrong I was. It's a clinically focused role, and actually for me, this person that I had who looked after me, they coordinated my whole care, right the way through from primary care out to other providers and right the way in. These people are actually doing integrated care now, and they're doing it really, really well, and this role is absolutely key. In my case, they actually help to explain about my condition. So if I had to go somewhere else, I could explain to the junior doctor that wasn't familiar with Hodgkin's lymphoma, how to treat it and what I was undergoing. But also I was able to ring them. I was able to say, I'm having this symptom. What does that mean? And they were able to say, well, you do need to go to hospital or not. And in my case, I think that saved about 2 admissions. So 2 worry admissions. So that's certainly a value in that role, and certainly important. Probably the biggest lesson I learned was about the role of the third sector. I didn't have any interaction with the third sector on the first journey, nothing at all. On the second journey, I had a huge amount of support from both small organisations and larger national bodies like that are here today. Traditionally, we know that the role of the third sector has been around end of life, funding capital projects, equipment, and providing patient advice. I benefited from those, but also it's about actually after cancer. Mr. Devane has spoken on the BBC the other day that 50% of cancer patients, 50% of people will experience cancer in their lives, and most of them will live, hopefully, for a long time. And actually the role of the third sector, I would argue, in the future is more about that long-term support after cancer. It's informal information. It's about learning how to live better, to live with your symptoms that you may be left with after treatment, and learning how to have a healthy life and to enjoy your life. I actually don't think it's a core health service. I think that sits with the vision of the third sector, which is to improve people's lives. And I think it's really important that this is a partnership between the third sector and the NHS, and it's certainly not wholly an NHS service. When I think about the challenges of the third sector, I think one of the difficulties they have is I understand their income stream is quite variable. So particularly some of the smaller bodies actually don't know what income they will have the following year. And actually one of the things for me is actually the NHS, with its relative stability, can work together in partnership with the third sector to provide some of that risk, to protect against some of that funding risk. So the message is actually the third sector needs to heavily involved on an ongoing basis beyond the traditional areas of before and after treatment. What I will talk about on the last bit is the new nightmare versus new normal. I went to counselling and one of the counsellors said to me, well, this is your new normal. This is your new life. You have to get used to it. The anxieties you deal with, the challenges you have. And it is my new normal. But actually, if I don't manage that well and I don't have the proper support, it turns into a bit of a nightmare. And if you think about, actually, the most important thing is to keep me at work, keep me healthy, keep me interacting positively with my family. And if I don't have that support, the impact on the health service is fairly phenomenal. The last point I'm going to talk about is about patient feedback. I've talked about how we have local district general hospitals and tertiary centres. I think there's an article in the HSJ in your pack which says that 40% of patients expect that hospitals are going to increase the number of services that are available to patients over the next decade. I think those of us who work for commissioners know that mightn't actually happen. It's really difficult to reform any pathway, but it's actually really a cancer pathway is particularly emotive. For me, I think we need to harness actually some of the messages. The message I'm saying to you is there's a huge difference between being treated at a tertiary centre. It's fantastic. It's really, it supports you, and it supports you before, during and after cancer. And actually we should support that, and we should make sure that message gets out in the public. And maybe we might understand how to reconfigure cancer services effectively. So I've talked about the key messages. I'd say try for chemotherapy, but for other conditions, try ambulatory care. Partner with a hotel before you, and actually see if you can move from day cases to an ambulatory care. I've learned to value the role of the CNS. It's an absolutely key role in preventing admissions. I've talked about the long-term partnership with the third sector. The third sector is dynamic. It is a very interesting place to work, and I think that we should work harder with the third sector to manage some of the challenges they have in funding some of our services on the long run. And we need to harness patient feedback. Final thing I guess I'm going to say is actually we need to work together. I guess I have one message from my experience, and actually it's enjoy every day, work very hard, and but make sure you enjoy every day, because actually you never know when it'll be your last.
Our second speaker is Ciarán Devane, who is the Chief Executive of Macmillan Cancer Support and is an excellent speaker. He manages a budget the size of a small country, I think, or even quite a large country.
Like Ireland.
And I didn't know until today that he used to be a chemical engineer, but there we are.
He did used to. I know a lot about the water content of the corn sausage. It was a very difficult problem to fix. Right. Well, I just want to fly through what Macmillan is thinking around commissioning cancer in the future. And our starting point really is the outcomes that cancer patients want. And as a result of a lot of work that we did, this is our summary of what cancer patients are saying. It's everything from being diagnosed early to having the right treatment, making informed decisions, being treated with dignity and respect, through to dying well. So the challenge as a commissioner is how to deliver this. Because, it's very good, it's very, aspirational, but how do you actually make it happen? And the second problem is, if you take cancer as the example of the ageing population, there is the story we were talking about last week. The number of people with cancer in 2010 is 2 million. The number of people with cancer in the UK in 2030 is 4 million. Now, the one thing we know is we're not going to double the resources. And if we're not careful, it'll be the long-term condition part of cancer which soaks up all the money. Because if you have somebody living 6 years rather than 1 and you're doing lots of follow-up appointments, you're by definition doing a lot more follow-up appointments. So the two problems we have to wrestle with is how do we deliver the outcomes in this context of increasing number of people getting cancer, increasing number of people living with cancer. So the National Cancer Survivorship for England was set up in 2008, and after 5 years of work and a very, very erudite report, what we came up with was essentially one big recommendation, saying if you're a commissioner and you only do one thing to address this problem, you should commission what's called the recovery package, which is around every patient should have a proper assessment and care plan. There should be a cancer care review, which is paid for by a QAF point anyway, so it may as well be a good one. And there should be a treatment summary record, which effectively is a proxy for good communication between acute and primary care. And then everybody should have this educational event at the end of treatment, which is a kind of a collective thing, which says, okay, now what do we need to do to support you as a group? And it'll be the good question you ask, which triggers a thought with me. So it's one intervention, and of course the power of it is that once you identify the needs in the care plan and you've got good communication between the patient and the clinicians in primary and secondary, then you get this early intervention which addresses the long-term consequences of cancer. And the other recommendation, if you ever asked me 5-6 years ago, the one thing I would not have said is that the major cancer intervention going on in Glasgow at the moment is Qigong classes through the libraries. I would never ever have thought that exercise was such a powerful intervention, but equally I would never have thought that we would be able to get that up and running. So the future, I think, for us is saying that there are few limited interventions which are affordable and the economics work, as I hope I'll show you in a second, which we can do, which will address this long-term condition aspect of cancer. And it's not only a cancer story. This is the front page of the Vision and Purpose of NHS England, but I love that last line as the strapline for NHS England because it's about high quality care for all, which gets you into the equalities question for now, but also for future generations, because the big challenge we all have as commissioners or people in the system is how do we make sure that there will be an NHS that's affordable and sustainable in the future. Every 4 years life expectancy in the UK goes up by 1 year. That's amazing, but it's a huge problem. So where we're coming from is saying that commissioning decisions need to be based on population evidence. It's really understanding what are the issues in Hampshire and how do they relate to what we need to do, and that there are 4 aspects to that. One is the numbers, the epidemiology. Second one is what outcomes are we achieving in Hampshire, what's patient experience in Hampshire. What solutions do we know are effective, and what can we steal shamelessly for elsewhere, and how does the money work? And if you don't address all 4, What we're saying is you won't be able to commission effectively for your population, because what we're saying is the future is in population commissioning. It's not about the tariff, payment by results, which is payment by activity. It isn't going to work. So what we need to build is how do we commission cancer services for all of Hampshire. So this is a real example. It's Sheffield, effectively. And saying you can look at the numbers of people, with, in this case with colorectal cancer in Sheffield, and see that they follow 8 different pathways, not one standard pathway as we all imagine, and you can attach the finances to those. So we know that if you take the person in the pathway on the left, it's a £9,000 pathway. Now clearly, that's somebody who lives less than a year, and we'd quite like them to move to the right. But if we do that, we are adding cost. So what do we need to do to make sure that the people who live 5 years and cost 14k are the preponderance, and the people who live 5 years and cost 24k are the minority? So what we can do is stratify the colorectal population in Sheffield by pathway, understand the costs, and understand the interventions which move people from one to the other. And they can be these small interventions I was talking about. And if we get that right and get proper population evidence, we can move to the world of commissioning cancer and everything else for pathways and populations, not for activity. Thank you.
Thank you very much. That was excellent. Our third speaker today is Jane Collins, Dr. Jane Collins. She's Chief Executive of the Marie Curie Cancer Care. She was previously a consultant paediatric and neurologist at Guy's, and then was Chief Executive of Great Ormond Street, and now Macmillan, now Marie Curie.
Marie Curie.
Sorry,
Thank you very much.
Get them well up.
Thank you very much indeed. I'll try and keep to time as well. I'm going to talk about integrated end-of-life care, because however fantastic cancer treatments have already become and will become, there will still be patients who die either of cancer or the impact of treatment on their cancer, and there are also more people dying of other conditions as well. As you all know, we have an ageing population, and there's going to be a steady rise in the number of deaths across the UK from about 2016. And we know that with an ageing population, more patients have more different conditions, comorbidities, multimorbidities. And we also know from some Nuffield Trust work that costs lots more. So the more multimorbidities a patient has, the higher the cost for hospital care is for a patient in the last year of life. And if you have 10 or more multimorbidities, then on average the cost for hospital care will be about £20,000. If you only have 1 or 2 multimorbidities in your last year of life, the cost will only be £5,000. Now, we believe passionately at Marie Curie that given that most patients want to die at home, that we should be helping them to achieve that. And we believe, and can show you in a moment, that we can achieve that through providing integrated care. Home is not the only option. Obviously, some people will die in hospital. Some people want to die in hospital. Others will need hospice care, but most people want to die at home. And the important message for you as commissioners is that will save money, and I'm going to show you how. One of the things which home care is better able to do is to provide coordinated care and to provide integrated care from the patient's point of view, and that's how we define it at Marie Curie. So we're looking at the patient's viewpoint, not at vertical integration across hospital services or integration of services themselves, but from what the patient and their family think. Integration is better at home and coordination is better at home, and that's shown on this slide. So the green block at the top on the hospital services, you can see that the bereaved families felt that coordination was much less good if a patient had been in hospital, which seems slightly odd really, because you'd imagine it might be easier to organise than when you look at all the different services that patients will often access in their communities. Home care workers, Macmillan expertise, hospices, OTs, and lower down a Marie Curie nurse in some cases as well. So despite there being such a panoply of providers to give that integrated feel for patients, actually it's achieved more often in home care than it is in hospital care. The problem, though, is when it doesn't work well. And the thing which really has struck me moving to Marie Curie is that the impact of a bad death. A bad death, from the family's point of view, lives with them forever. It doesn't live with us who are necessarily involved, but for the individuals and families, it's something they remember forever. And so, therefore, when we don't do it well, when we aren't well coordinated, when it's not integrated, it can impact on quality of care, pain control at home, and also the place of death. So if we look at the quality of care by location, again, this is feedback from bereaved families. Actually, the best care is provided at home, hospices or care homes. And I think sometimes care homes get a rather poor press in the media. And actually, care homes and hospitals are equally good, care homes and hospices are equally good at managing deaths. And I think that's something that perhaps we ought to be celebrating rather more. The area that we're less good for supporting families and patients at home for a home death is, however, pain control. And there's a lot more work that needs to be done. Not surprisingly, hospitals score best here, hospices coming very close behind that, and care homes and the patient's home score least well. So we at Marie Curie, working with other charities like Macmillan, need to be doing more work to improve pain control. We've done some work comparing patients who we looked after in their last weeks, usually, of life, and matched controls. This was a piece of work done by the Nuffield Trust, so an independent assessment. And we were able to show that where Marie Curie Nursing Service were involved, 77% of those patients died at home, whereas 35% of the matched controls did. But also, equally importantly, 8% of the patients we were caring for needed hospital admission at any point, whereas 42% of the non-Marie Curie cared for group needed hospital attention. So you can see right away the impact of providing an appropriate package at home, particularly patients being supported at night when the families may lose confidence about whether they can cope with their dying relatives' care at that point. And we've done some work over the years which was done by my predecessor, so I can take no claim for it, but something called the Developing Choice Programme. And we've now been doing this in 19 different sites across the United Kingdom, and we're launching a huge piece of work across the whole of Northern Ireland on Monday when I was in Belfast. But we worked particularly with Somerset, which is obviously a more rural community, really helping them understand what they felt was right for the population they serve. It's obviously a mixture of towns and rural population. And working together, we were able to provide support for them to come up with a design of a service for the whole of Somerset, very much involving patients and their carers as well, to come up with a design which improved the chances of the patients being able to die at home. And we know that dying at home is cheaper. We've also done a piece of work in an inner-city area with the Greenwich Care Partnership. And two of the key points from that piece of work was the importance of having a rapid response service to provide support, perhaps when either professionals or the family were losing confidence, but also having a key worker role so that there was very clear coordination so that the services could be organised, again, to best meet the patient's needs. So we have experience of doing that. We're really keen to work with more areas across the country because although there have been great strides forward in end-of-life care over the last 5 or 6 years, we still have less than half of the patients who want to die at home being able to achieve that. They want to do it. It is cheaper and therefore better for the NHS. We should be working much harder so more patients can achieve what they want, and that is death at home. Thank you very much indeed.